Priapism is a condition in which a penis remains erect for more than 4 hours in the absence of stimulation or after stimulation has ended. Priapism is a prolonged and often painful erection of the penis that lasts more than 4 hours and is not related to sexual stimulation. It is a urological emergency. A prolonged erection of the penis, usually without sexual arousal. Priapism is an unwanted, persistent erection. It may occur spontaneously or from certain antidepressants or erectile dysfunction drugs. Some sources give a duration of 4 hours as a definition of priapism, but others give 6, the duration of a normal erection, before it is classifiable, as priapism is still controversial. Ongoing penile erections for more than 6 hours can be classified as priapism. Types of priapism. 1. Ischemic low-flow priapism, most common and serious type, caused by blood not being able to leave the penis. 2. Non-ischemic high-flow priapism, less common, usually less painful, caused by unregulated blood flow into the penis. 3. Stuttering priapism, recurrent episodes, typically in patients with sickle cell disease. Causes. 1. Ischemic priapism. Hematological disorders, sickle cell disease, leukemia, thalassemia. Medications. Erectile dysfunction drugs, for example, sildenafil. Antipsychotics, for example, risperidone. Antidepressants, for example, trazodone. Anticoagulants. Substance abuse, alcohol, cocaine. Trauma, genital or perineal injuries. Idiopathic, no identifiable cause in many cases. 2. Non-ischemic priapism. Perineal trauma, for example, bicycle injury leading to fistula formation between an artery and the corpus cavernosum. Priapism in females continued. Painful erection of the clitoris is significantly rarer than priapism in men and is known as clitoral priapism or clitorism. It is associated with persistent genital arousal disorder (PGAD). Only a few case reports of women experiencing clitoral priapism exist. Signs and symptoms. Because ischemic priapism causes the blood to remain in the penis for unusually long periods of time, the blood becomes deprived of oxygen, which can cause damage to the penile tissue. Such damage can result in erectile dysfunction or disfigurement of the penis. In extreme cases, if the penis develops severe vascular disease, the priapism can result in penile gangrene. Ischemic priapism. Erection lasting greater than 4 hours. Penis shaft is hard, but the glands may be soft. Painful erection. Lack of sexual arousal may cause permanent damage if untreated. Non-ischemic priapism. Prolonged erection, often for hours. Usually not painful. Often follows trauma. Penis is partially rigid. Prevention. For sickle cell patients, proper disease management, hydration, hydroxyurea. Medication review. Avoidance or careful use of known trigger drugs. Avoid illicit drugs and excessive alcohol. Prompt treatment of early symptoms to prevent recurrence. Diagnosis. The diagnosis is often based on the history of the condition as well as a physical exam. Blood gas testing. The blood from the cavernosa of the penis can help in the diagnosis. If the low-flow type of priapism is present, the blood typically has a low pH, while if the high-flow type is present, the pH is typically normal. Color Doppler ultrasound may also help differentiate the two. Testing a person to make sure they do not have a hemoglobinopathy may also be reasonable. Penile ultrasonography with Doppler is the imaging method of choice because it is non-invasive, widely available, and highly sensitive. By means of this method, it is possible to diagnose priapism and differentiate between its low and high flow forms. Treatment. Medical evaluation is recommended for erections that last for longer than 4 hours. Pain can often be reduced with a dorsal penile nerve block or penile ring block. For those with non-ischemic priapism, cold packs and pressure to the area may be sufficient. Ischemic priapism emergency. 1. Initial steps. Ice packs. Physical exercise. Oral pseudoephedrine under supervision. 2. Medical treatment. Aspiration of blood from the corpus cavernosum. intracavernosal injection of alpha agonists, for example, phenylephrine, analgesia and hydration. Treat underlying cause, for example, sickle cell crisis. 3. Surgical options if unresolved. Shunt surgery to drain blood. Non-ischemic priapism. Observation may resolve spontaneously. Embolization of the artery if persistent. Stuttering priapism. Hormonal therapy, for example, GnRH analogs, anti-androgens. PDE-5 inhibitors paradoxically used for prevention in some cases.
If you find this video helpful, like, subscribe or follow my Health by Dr. J for more important health videos.